Sir, you are live. You can start.
Uh, Very good evening, everyone. Again, we welcome you to ISG Masterclass. As you are aware, that Indian Society of Gastroenterology is organizing masterclasses for residents and all the gastroenterologists in our country. Till now, we have done four lectures in this series, and all four have been quite successful. We had an audience varying from 1,500 to 2,000 in each of these webinars. We have also posted a feedback form 3 days back. I hope you received it, and I'm sure that some of you have already responded to, and we'll wait for a couple of days before we receive all the responses and get back to you what were our observations and what suggestions you gave us. We also request you to please post your feedback in terms of quality, in terms of the audiovisual effect, in terms of speakers and their contents. That will help us improving the quality of these webinars. As I said earlier, that we intend to continue with these webinars in the future also, even we come out of this lockdown state. One more point I want to highlight at this point of time, that while we are in the midst of this pandemic, but everybody in the pandemic is working, governments, media organizations, scientific societies, and everyone is working hard to get over this crisis. And we believe that this is the best phase of humanity one has ever seen. Everyone is so decent and so supportive that we are able to fight this pandemic all over the world. And we believe that by this pandemic, the whole world has come much closer. So with this basic introduction, let me also welcome Dr. Shobna Bhatia. She has consented to moderate this session. And all of us know Dr. Bhatia, he's a very renowned teacher and renowned gastroenterologist of our country. She had been head of KEM gastroenterology department. And now, so we welcome Dr. Bhatia for your kind consent to moderate this session. Welcome Dr. Saraswat, and I request Dr. Saraswat to say a few words before we request Dr. Ghoshal to talk to us on very important topic and not easy to understand, esophageal manometry and impedance. Basic concepts and how do we use in our practice and how do we interpret these findings. With this, Dr. Saraswat, please.
Thank you, Govind. Good evening, everyone. On behalf of the Indian Society of Gastroenterology, it's a great pleasure to welcome you to this ongoing series of ISG masterclasses, to which I'm happy to say we have had a very gratifying response. Govind has told you about the background and how we plan to propose to continue with this meeting. In this fourth talk of the series, Professor Uday Ghoshal, whom you all know very well, and is one of the leading names in the field of esophageal, of GI motility, GI manometry in India and globally, will be speaking to you about esophageal manometry and impedance. And I can promise you, you are in for a treat. Because Uday's lectures are always very lucid and clear, and his audience is able to understand what is going on. Now, the way the talk this evening will proceed is that Dr. Ghoshal will speak for about 20 minutes or so to complete the first part of his presentation, when we'll break for about 5 minutes, and questions that are sent in by all of you on the chat box, which you can see at the bottom of your Zoom screens, will be screened, and Professor Shobna Bhatia, Dr. Makharia and myself will be handling this, but mainly Dr. Bhatia will be attending to this. Then Uday will complete his talk in the next 20-25 minutes. And at the end of it, we hope to have another 10-15 minutes during which we will address the questions being raised by the audience. As we have done in the previous talks, the unique questions that do not get answered during the live interaction will then be answered and posted by email as well as on the ISG website. As Govind has told you, we do plan to continue this series of lectures. And beyond 20th, we await your feedback, your suggestions and inputs. Not only how have these series gone, but what are the topics and areas that you would like to be covered by ISG master classes if in the ongoing series. And with these few words, and I'll request Professor Uday Ghoshal now to deliver his talk to you on esophageal manometry and impedance. Uday, over to you, please. Uday, we are waiting for you. Please unmute yourself and get started with your talk.
Yes. So thank you. Uh, Greetings from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Indian Society of Gastroenterology. Thanks to Professor Gobind, Professor Saraswat, and Professor Bhatia. I'll be giving you a basic concept of esophageal manometry and impedance. But let me tell you, in such a short time, you cannot become master, but you get the concept. If you want to know more about it, you can refer to these two books. Both are from our group. And I tell you, the left one gives you basic technique of performing the manometry and interpreting it. The right one gives everything, including theoretical aspects and the disease management. Now, when we talk about esophageal testing, you thought it is all to do with structure. That means we do radiology, we do endoscopy, and we do histology, and we are done. So in endoscopy, you can talk about conventional endoscopy, advanced endoscopic technique, esophageal capsule endoscopy, and US. I tell you, this is very little. There are a group of disorder which are related to abnormal physiology, and those abnormal physiological disorder give symptom, but the structure may remain normal. So how do you assess this disorder? These are tested by esophageal manometry. Earlier we used to do conventional, now we do high resolution manometry and impedance monitoring. Also, some centers do high frequency endoluminal ultrasound, very research oriented, you need not know. We do pH metry for assessing acid in the esophagus, which can be catheter based or Bravo capsule. Nowadays, we do impedance pH metry, and transit is assessed by radionuclide esophageal emptying. Now, I'll focus primarily on esophageal manometry. But let me tell you, I'll give a little bit what everyone can do, because I know in this country, maybe there are 200 odd manometry center, but there are many more gastroenterologists in the country. So I'll give a little bit more than manometry. So what are the indication of esophageal manometry? Dysphagia without any mechanical obstruction. This we call as motor dysphagia. Non-cardiac chest pain, where there's a pain in the esophagus, with or without dysphagia, but the cardiac workup is inconclusive. Gastroesophageal reflux disease, you will say, why should I do manometry in gastroesophageal reflux disease? When you do pH metry, you have to do a manometry because this is the best way to localize the LES and then place the esophageal manometric catheter about 3 to 5 centimeter above the upper margin of the LES. That is why you do. But also it gives you prognosis. For example, those patients with GRD who has very low esophageal LES pressure, those who have very poor esophageal motility actually have severe GRD. Systemic diseases with esophageal involvement, for example, myasthenia gravis, for example, progressive systemic sclerosis. And when you suspect US dysfunction or upper esophageal sphincter dysfunction, still you do a esophageal body manometry to know that truly it is primarily an US dysfunction or there is something more in the esophageal body. Now, when you are actually encountering such a patient, you have to determine what patient are you dealing with. Are we dealing with a mechanical dysphagia or are we dealing with a motor dysphagia? And I tell you, nowadays in the arena of investigative medicine, the clinical medicine is going away. But I tell you, you'll miss a lot if you forget clinical medicine. Most is typically intermittent. They have dysphagia both to solid and liquid from the very onset. You know why? Because liquid require better neuromuscular coordination to swallow than solid. Therefore, this patient may report problem with liquid even from the very beginning. Warm temperature food are better tolerated by this patient. They can't really swallow the cold. They learn with time that if they raise their arm, they make their back erect, actually they can swallow better. You know why they are doing that? They are trying to compress the esophagus between the manubrium, sterni, and vertebra, increase the intraesophageal pressure, and trying to pop up the content through the LES, which is not relaxing. Duration is really long for motor. Episodic esophageal chest pain suggests motor disorder. Regurgitation is very highly suggestive of motor dysphagia. In fact, these patients have dilated esophagus. That's why they regurgitate. And weight loss is minimal in motor, but more so in mechanical. Once you know you have a patient with motor dysphagia, you have taken history, you have done physical examination, then your choice of investigation start with upper GI endoscopy and or barium swallow. If you ask me, we do not subject this patient to endoscopy in the first go. You know why? Because most of the time they turn out to be achalasia, and I know I have to dilate them. So therefore, why to give them trouble of doing endoscopy twice? Because endoscopy is not so comfortable. So what we do is either we do a barium swallow, not really swallow, I'll tell you what we do. But most of our patients carry one of these investigation from outside, and this makes our life easy. If you find a stricture, you know this is mechanical, this is not motor. But if you find no stricture, you do an esophageal manometry. Occasionally, a barium swallow shows something like this. On the left side, you can see dilated esophagus with multiple tertiary contraction. In the middle, you can see a hugely dilated esophagus, which is more than 7 centimeter. We call megaesophagus. Megaesophagus and sigmoid esophagus means this is a decompensated esophageal disease. Don't consider that decompensation applies only to cirrhosis and not to esophageal disorder. And if this has happened, the patient usually have a poor prognosis. On the right side, you can see a classic corkscrew esophagus. But we do not do barium swallow for this patient. If you have been doing, please stop that. The better information you obtain from time barium esophagogram. What is time barium esophagogram? You give 100 ml barium, 45% weight by volume. Then you do X-ray at 1, 2, and 5 minutes. See the height of the barium column at 1, 2, and 5 minutes. Also see the volume at different time. And what happens is the volume and the height product gives you the esophageal emptying. So if somebody has a high volume, he has a greater height, this fellow has poor esophageal emptying because of body dysmotility and because of non-relaxation of LES. Is a very good investigation and correlate well with our manometry finding. But let us come straight to manometry. What is manometry? In manometry, typically what we do is that we have x-axis. In the x-axis, it is time. It is time. That means you are recording the swallows in a patient on the x-axis at different time, typically at an interval of 15 to 30 seconds. On the y-axis, this is amplitude. So we get an amplitude of the contraction, we get a time, and therefore we can see that lower esophageal sphincter, like 2 channels in the bottom of this manometry tracing, they are relaxing, and you can see the body contraction. There is a progressively increasing amplitude. Also, there is a progressive delay as the contraction travels down. This is called peristalsis. Peristalsis is like a slope, so that when the upper part of the esophagus is contracting, the lower part is relaxing to receive the food bolus coming down. But what happened is this technology was an old technology, was being done about 25 years ago. Now we have changed now. And the change was brought by this gentleman. His name is Ray Klaus. Ray Klaus was a student of geography. Therefore, he used to see the mountain range in 3 dimensions. So he wanted the manometry, because later he shifted to medicine, and he wanted manometry to become 3 dimensional. So what he did is, x-axis remains the time, y-axis is the esophageal length. But you will tell me that if y-axis is esophageal length, x-axis is the time, how do you represent the amplitude of contraction? This smart man, what he did is, he said, I'll give different colors to different degree of pressure. So I have made an analogy. I don't know whether this man thought about it or not. The analogy is with the nature. The nature, if you look at, sea is blue. As you go deeper to the sea, it is more deep blue. As you go to the paddy field, it is green. Go farther up, it is yellow. Sky is yellow when the sun is setting. Still up, the sky is red with the setting sun, and the top of the sky is dark. So therefore, this is the color amplitude coding. The blue color represents the most negative pressure, black color represents the most positive pressure, and different shades of blue, green, yellow, orange, and red is higher and higher pressure. So therefore, this is called high resolution manometry. That's why these are called Klaus plot. It goes by the name of Klaus, that here esophageal length is represented in y-axis, time is represented in x-axis, and the color represents the amplitude of contraction. Now let me give an example. This is one of our patient where you can see that above there is a blue. This is pharyngeal pressure. Below that you can see there is a high pressure zone, red and green. This is actually upper esophageal sphincter pressure. Then you can see the lower, this is again blue. This is intrathoracic pressure. And then still below, you find there is a high pressure zone. This is lower esophageal sphincter. And still below, there is a negative pressure zone. This is gastric pressure. And you can see with each swallow, upper esophageal sphincter is open because pressure has become blue. And then there is a progressive contraction as it travels down. The pressure is higher and higher. And there is a clear-cut slope. That means the lower part is contracting much later than the upper part of the esophageal body. Now, therefore, you will ask me, what is the difference between this conventional and high resolution manometry? One is the way it is displayed is different. It is displayed with color, which looks very attractive. People did not like those EGG or EMG or ECG type graph, but they like now because this is a color plot, this is a 3D plot. But more than that is actually number of port. Earlier, when I used to do manometry when I was a DM student, we used to have 6 or 8 ports. So 6 or 8 port means 2 port will be in the lower esophageal sphincter, 1 port to the stomach, and 4 or 5 port will be in the body. So esophageal body is so long, see, like 30 or 40 centimeter. And there, if you give 1 port every, if you give 4 or 5 port, you have 1 port every 6 centimeter. So if you have 1 port in every 6 centimeter, if this is the contraction of circular muscle is the one which is recorded. You know why? Because circular muscle impedes the flow of water through the port in which water is flowing, that is manometry port. So if there is a circular muscle contraction as shown in the left side, which is squeezing the catheter between the port, this contraction will not be recorded. On the other, on the right side, I have shown a high resolution manometry where varying between 32 to 64 ports catheter are there. So if it is 32 port, almost every 1 or 2 centimeter you have a port, so there is a lesser chance that this contraction will be missed. And therefore, it records more number of contractions. Also, the conventional manometry often used to be water perfusion system, whereas high resolution manometry is often solid state system, and solid state does not lead to delay in the recording of the contraction that happens in the esophagus into the computer which is located outside. Since this is a little complicated, I'll skip this. I'll bring you to the concept of impedance, because when we are talking about manometry, Govind asked me to talk not only on manometry, but manometry impedance. So what is impedance? Impedance means electrical resistance. Electrical resistance. So if, let us say, I have a catheter which has port, impedance port, and is lying in the esophagus. So obviously esophageal lumen has a baseline impedance. So let us say this is the baseline impedance. Now the fellow swallows, and this is a liquid bolus. When the liquid bolus travels through the impedance port and touches the two impedance port, what will happen is, we all know, the electrical resistance get reduced in the fluid media than in the gas media. So therefore, the resistance will reduce as the bolus enters and touches the two impedance port. Now, when the bolus is passing through the two impedance port, again, the resistance will remain low. And then subsequently, when the bolus escapes these two ports, again, the impedance will go up. So typically what will happen is, if I swallow a liquid bolus, and if I am doing a manometry along with impedance, what will happen is impedance will give that bolus has crossed, and the manometry will give me the pressure. So the pressure is the activity of the muscle that the manometry will give me, and the bolus passage will be given by impedance. Remember one more thing here. Like a liquid bolus reduces the impedance, gaseous bolus increases the impedance. So therefore, somebody belches, you can see that, because belching is associated with passage of gas. Similarly, somebody swallows air because of aerophagy, you can see that, because the impedance will go up. Now, let us take this simple example. Here you can see this is the esophagus. In the esophagus, you can see there are multiple manometry ports, the round ones, and also there are multiple impedance port, the boxes, the dark boxes. Let us say the fellow swallows a liquid. What will happen is, liquid bolus will pass, and as it passes, you can see the white lines there on the right side is actually the contraction of the circular muscles, which is recorded by manometry system. And the red lines there is the impedance recording, which shows the bolus has crossed. So therefore, let us compare with cardiologists. The cardiologist uses echocardiography to see the flow of blood, and they use ECG to record the muscular contraction, because electrical event lead to muscular or mechanical event. So let us compare this mechanical event somewhat like ECG activity, that is manometry, and the bolus passage is like echocardiography, that is passage of the blood. So let us come to types of peristalsis. Peristalsis can be primary, can be secondary, can be tertiary. What is primary peristalsis? Primary peristalsis is a swallow-associated peristalsis. Primary peristalsis is a swallow-associated peristalsis. How will you show that whether it is swallow-associated or not? If you see that US pressure has become low, and then there is a passage or there is a peristaltic event, this is primary peristalsis. On the other hand, if you find the US pressure did not become low, that means US did not open, still there is a peristalsis, this is a secondary peristalsis. Therefore, left side of this signal, you can, or tracing, you can see a primary peristalsis where US has opened, and the right side, you can see a secondary peristalsis where US did not open. So this is not one of the best spontaneous example. I induced it, but for the simplification. And what is tertiary peristalsis? Tertiary peristalsis is like atrial fibrillation, where there is any mechanical activity hardly at all. And you can see here the impedance. The impedance is recorded by, again, color. Purple color means fluid, whereas white means that the impedance port is touching the mucosa. So white means impedance port is touching the mucosa. Now, purple means it is liquid, and blue means there is air. And you can see here, the fellow has swallowed. When he swallowed, you can beautifully see that esophageal contraction has happened, ileus has relaxed, and fluid has gone to the stomach. But can you see a long break in the middle of the esophagus? This is called peristaltic break. And because of that peristaltic break, there is a bolus escape. What is bolus escape? That means all of the fluid has not gone to the stomach, only some has gone to the stomach, and the remaining is retained in the esophagus, and this we call as a bolus escape. You will tell me all these theoretical things you are speaking. Let me come to a real life example, because I know most of you are practicing clinician. You like to learn from example. This is a 19-year-old son of a doctor, and he himself is a third-year medical student. You'll say, why are you telling that? I'm trying to tell you, this is what is happening to a doctor who understands quite well. He had dysphagia, regurgitation, and occasional heartburn, but no chest pain for 1 year. You'll say, oh, dysphagia, regurgitation, must be achalasia cardia. Possible. Upper GI endoscopy is normal, and high resolution manometry done elsewhere was diagnostic of type 1 achalasia, and he was planned for a POEM. POEM is endoscopic, you see, parural esophageal myotomy, parural endoscopic esophageal myotomy. So one will take the endoscope down, then will cut the sort of esophageal mucosa, tunnel through the submucosa, then cut the LES muscle. Now he was planned for that. Now he got a barium swallow done. It shows somewhat dilated esophagus, but not typical parrot beak. No problem, it happens sometimes. Now still, because the POEM is very destructive procedure, this doctor thought, he is himself a surgeon, he said, let me go for a second opinion. And we did a manometry. And what we found is, yes, he has a beautiful US. The US is relaxing with each swallow. Now, yes, there is hardly any contraction. The contraction looks quite simultaneous. The LES looks like relaxing a little bit. Can you see there? LES is relaxing a little bit. But still, superficially, if you look at it, you may say, oh, this looks like achalasia type 1. But look at the impedance above. The impedance shows that fluid is practically going down to the stomach. There is hardly any bolus escape. So this raised a suspicion to us, because we found his LES is relaxing and there is a beautiful flow of fluid down. So in our system, we can overlay impedance on the pressure. So we overlaid the impedance on the pressure, and you can see each time there is a contraction of the esophageal muscle, though it is looking like simultaneous, there is a fluid passing into the stomach. So hardly there is much bolus escape, except a little bit above there. So we wanted to make a 3D. I don't know whether 3D can be shown in this video conferencing. Just let me know it is showing. What you can see in the 3D, when he is swallowing the bolus, US is opening, bolus is going down, entering into the stomach, and then refluxing back. You want me to replay once more? Okay, sorry. Okay, I can't replay this. No problem. So I'll replay from here. Okay. Now look at this. What is happening is, when he's swallowing, US is opening, bolus is coming down the esophagus, entering fully into the stomach, and then refluxing back. So is it reflux esophagitis? So what happens is, we did a 24-hour pH metry, and it was a patient with severe gastroesophageal reflux disease. So you can understand what would have happened if you would have undergone a POEM. So why manometry appeared like this? Manometry appeared like this because he doesn't have any esophageal muscle, hardly any esophageal muscle. It is like severe scleroderma type esophagus. This may be myopathy, this may be neuropathy, more likely to be myopathy of the esophagus. So what was happening is, each time he was swallowing, the catheter gets pulled up a little bit, and that pulling up of the catheter creates some flicker-like activity which looks simultaneous. So this sort of error can happen, and that tells you that the sophistication in the system is required before you do a lot of invasive procedure. So now let me come to achalasia then, because I referred to you type 1 achalasia. Now let me tell you what is type 2 achalasia and what is type 3 achalasia. Type 1 achalasia means no esophageal pressurization like our patient had. Hardly any esophageal muscle activity. In fact, the example that I displayed here is not the right example. The example would be, there will be one US activity above, one will be LES activity below, there is nothing in between. Type 2 means pan-esophageal pressurization. That means the muscle is still there, but it is misbehaving. it is contracting simultaneously. This is throughout the esophageal vein. And type 3 is segmental esophageal pressurization, which means muscle is there, it is misbehaving, but misbehaving only in one segment. And let me tell you, pathophysiologically, type 3 is the early disease, type 2 is little later disease, type 1 is the worst disease or most late disease. That means most of the type 1 may be having esophageal decompensation. And I tell you, Nitesh Pratap from India showed that type 2 respond best to pneumatic dilation. You know why? Because the muscle is still intact. So therefore you disrupt the LES, the fellow will swallow better. It is like if somebody has aortic stenosis and now the ventricular muscle is still intact, you do aortic valvotomy, you will get a better relief than if somebody has ventricular muscle has become flabby and now he has left ventricular failure. You do aortic valvotomy, it will not work so well. So let me come to this example just to show you what achalasia means, and we stop here and take question because I've already taken 25 minutes.
So,
Stop.
Dr. Shobna?
Yeah, so we have a lot of questions already, and I'll just take a few. Uday, what you started off with a fantastic thing about the technique, but a lot of questions that have come are related to the procedure itself. Like, do you use water swallows or semi-solid swallows? Do you use rapid drinking challenges or multiple rapid swallows? Do you think you want to discuss it now, or you can send these answers?
I'll discuss briefly.
Yes, please.
Because Govind told me specifically make it general concept, but
Yes.
still good question has come. I tell you that if you are using a water perfusion manometry system, we use water swallow. But if you are using a solid state system with impedance, we use saline swallow because
Yes.
saline lowers the impedance more. As per recommendation, just don't stop by 10 water swallow or 10 saline swallows. You have to do a multiple rapid drink challenge and you have to do a viscous swallow. Typically, when we bought our manometry machine, applesauce came with it, but I think applesauce is too costly. We use simple card from our canteen to give viscous.
Correct. Okay, what about rapid drinking challenge and multiple rapid swallows? Do you use that?
You see, we use multiple rapid swallow. So because you see, many a time, if a fellow has mild disorder, if you give the esophagus rest and ask him to swallow, actually you may get normal. Whereas when you challenge the esophagus with multiple swallows in one go, esophagus may show abnormality. So as a part of the routine, you are supposed to do multiple rapid swallow.
Okay. Now, most of the other questions are related to the types of machines that are available. Is there a difference between 16 and 36 channels? I think you already explained that when you have 36 channels, you get a better definition.
Yeah, as you increase the number of port, your definition will be better. We manometry people call it fidelity. What is fidelity? Fidelity means reliability. So we are more reliable. But I tell you that for practice, there is reliability doesn't matter. Achalasia will be sold as achalasia whether you use a water perfusion system or solid state system. But if you are into research and you want a lot of matrices to report as the research data, we want multiple port and solid state. But for practice, solid state is not doable because each catheter costs 15 lakh Indian rupees and one catheter will give you 400 manometry. Though in our lab, we have done 1200 manometries with one catheter, luckily. But still it was very expensive. Now about second question you asked is, what was that?
What is any difference between so many companies that are making these machines?
Whatever machine you are using, you become familiar. We have four machines in our lab. One, we have Hibbard system, which is a water perfusion system. Recently, we received a donation ELISAR system for research. Now we have a Sandil system, which is solid state, and pediatric gastroenterology people have MMS system. I've used all this system and all are good.
Yeah. So what is the difference between using 5 ml and 10 ml swallows?
You see, as you give higher volume swallow, what will happen is your vigor of contraction is going to be better. You know why? You remember Starling law, which was taught to us in cardiology in first year and second year. Starling law says that when you stretch a muscle, it contracts more vigorously. So if you give 10 ml swallow, the muscle will contract more. Typically, in our place, we give standard 5 ml swallow. If you want 10 ml swallow, you use 10 ml swallow, but consistently. You can't just give your cases 5 ml swallow, control 10 ml swallow, and produce data which looks significant. So you have to use consistent volume. We use 5 ml swallow.
Okay, so Uday, there are many more questions on how to analyze the manometry tracing, but I think part of it will come when you come to the rest of the presentation. So I will stop the questions now and we go to the, we continue with the presentation.
Thank you so much.
Can I ask you one more thing?
Yes.
Ghoshal, can you use your pointer while you talk about tracings? So we can go along with you on this tracing.
Tell me, will the pointer be shown?
Yeah. If you put your desktop can be shown.
The cursor on the
Cursor.
computer.
Okay, no problem. I'll use. Now let us go to the next. Somebody will say, I remember one of our teacher used to say in the early days when you were doing DM, what is the value of doing manometry in patient? Because there is no value. I can say from the symptom and a barium swallow this is achalasia and I dilate. I tell you it's not right. Because manometry is the gold standard for the diagnosis of achalasia. And today in the days of litigation, if you have dilated somebody with a presumptive diagnosis of achalasia and perforated and it goes to the court, nobody can save you. No expert will recommend dilatation or anything without manometry. It is the best test to differentiate from other motility disorder, for example, diffuse esophageal spasm. It helps you to subtype achalasia, and I tell you, if you get type 3 achalasia, then you have to straight given something else because most of the patient pneumatic dilation fail in type 3 achalasia. Sometime when barium and endoscopy doesn't show any change, manometry will give you diagnosis. Even we know some cases where nothing worked, if you challenge the early achalasia with cholecystokinin, you can give the diagnosis before even manometry shows abnormality. Post-pneumatic dilation LES pressure suggests adequacy of pneumatic dilation. So therefore, you know you have done a good job. Otherwise, the fellow will recur and all those painful things will happen. When you treat a patient of achalasia, and if he is type 2 achalasia or type 3 achalasia, and in addition to dysphagia, he has pain, tell the patient that my dilation is going to help your dysphagia, may not help the pain. Pain may burn out with time. Also, variant achalasia and diffuse esophageal spasm may require different approach. For example, if there is a variant achalasia with a long spastic zone, you may require an extended Heller myotomy or extended poem. So therefore, manometry is very, very important. Now, what is value of manometry in GRD? Severe GRD is more often associated with the reduced amplitude of contraction in the lower esophagus and LES pressure below 6 millimeter of mercury. And I tell you this is important. Like the first patient that I showed you had a very low LES pressure and had hardly any contraction in the lower body. Now this patient should ideally don't go for fundoplication because post fundoplication is going to have dysphagia. If at all you venture to do a fundoplication, make a loose wrap. Though randomized control trial, don't substantiate this, but everything cannot be answered by randomized control trial. This patient has also to be told in the beginning that you will require a high dose lifelong PPI. And many of these patients we treat in addition to PPI and prokinetic with pyridostigmine because pyridostigmine improve esophageal motility. Such patient, I told you, these are ideal candidates for surgical treatment if the body motility is reasonable. Okay. Now I'll skip this slide because this talks about pathogenesis of achalasia, the relationship between cholinergic activity and nitrinergic activity. But I know this will take a little long. If you want, you can go to this paper of ours published in World Journal of Gastroenterology in 2012, and it is a free full text article. Now, when you do esophageal manometry, this is the machine we are looking for. This machine that I have shown here is a solid state machine, but obviously there is a water perfusion machine in addition. Now, typically lower esophageal sphincter normal value is 20 to 35 millimeter of mercury. Earlier in the conventional system, we knew the upper limit is 40 millimeter of mercury. Now in the high resolution system, this is 35 millimeter of mercury. Now, lower value is 20, but remember one thing, that even somebody is 18, 15, it is good enough. When below 10, we say abnormally low. Below 6, really bad. So therefore, the lower value, there is a borderline zone. Now there is a trunk in the middle of the esophagus, and this transition zone reflects that this area has both smooth muscle and skeletal muscle. Now, this area should be less than 2 centimeters. If it is more than 2 centimeters, it is abnormal. It is abnormal. And this may lead to dysphagia. Now, what is the mechanism of swallow? The moment somebody swallows, the bolus goes inside the esophagus. This bolus leads to a pressure, and this is called intrabolus pressure. Can you see here? When the EUS has opened, the intrathoracic pressure has become higher, and this is because of intrabolus pressure. Now, the moment bolus has entered, the circular muscle of the esophagus proximal to the bolus contracts. Both longitudinal contracts and circular contracts. But typically, the manometry is recording primarily the circular muscle activity. So, circular muscle of the esophagus contracts. And this circular muscle contraction gives rise to what is called esophageal contractile front. Esophageal contractile front. Now, what happens is, the moment this happens, remember one thing, when EUS happens, through the vagus nerve reflex the LES opens. So, EUS opens, through the vagus nerve, reflexly the LES opens. So, EUS opening is associated with the LES opening. There is no delay. Now, this is here, LES has opened. Now, when the LES opened, there is a residual pressure in the LES. This is called integrated relaxation pressure. The integrated relaxation pressure is, it is a lowest average pressure over a 4-second window, which need not be continuous after the swallowing. After the swallowing means after the EUS opening. So it is a average minimum pressure. It is the average minimum pressure over a 4-second window, which need not be continuous. That's why you see there are white boxes. It has sampled the lowest pressure. And then this is integrated relaxation pressure. If integrated relaxation pressure is reasonably much below the esophageal contractile front, then the bolus moves. So when does dysphagia occur? If esophageal contractile front is very weak, for example, much weaker than IRP or integrated relaxation pressure, then dysphagia occurs. If IRP is high, then dysphagia occurs. So the combination of these two, it is the esophageal contractile front pressure and the IRP, the combination of these two explain dysphagia or disbalance between the two explain dysphagia. What is the concept of DCI or distal contractile integral? Earlier, we used to represent the contraction amplitude by Earlier, we used to represent the contraction amplitude by average amplitude. Now we do not represent it or express it by average amplitude. We express it by distal contractile integral or DCI. You also, where from this DCI came? I tell you, DCI was there very much. DCI was there in the small bowel manometry. In the small bowel manometry, this was not called DCI, but it was called motility index. What is motility index? Motility index is amplitude of contraction into duration of contraction into number of contraction. Because in the small bowel, there are repeated contraction. Like once migratory motor complex comes in the duodenum and jejunum, you will get 12 contraction in a minute. So all these 12 contraction gives to area under the pressure. So therefore, in the small bowel to express the contractile vigor, people designed long ago, decades ago, motility index. What is motility index? It is amplitude of contraction into duration of contraction into number of contraction. Because in the esophagus, you are dealing with only one contraction. Therefore, the number of contraction is not there. It is amplitude into duration. So DCI means it is the amplitude of contraction into duration of contraction. What is contractile front velocity? Contractile front velocity means if there is a contraction activity here, let us say here in the middle of the esophagus, and there is a deceleration point here in the lower part of the esophagus below ileus. Obviously, we know the time from the x-axis. How much time did it take? Now, if the time taken, I know for this many centimeter, I can calculate what is the velocity. So per second, how many centimeter is it traveling? If the velocity is more than 8 centimeter per second, it is bad. It means it's simultaneous contraction. So if you are too fast, if you have an esophagus which is too fast, you have a bad esophagus. It causes simultaneous contraction. It should be lower than 8 centimeter per second. That should be the velocity. Now, these are the normal value that I already told you, but briefly I am telling you that esophagogastric junction pressure should be between 20 to 35 millimeter of mercury. Lower limit is 10. And when it relaxes, the IRP should be below 15 millimeter of mercury. When it relaxes, the IRP should be below 15 millimeter of mercury. Here it is written nadir pressure. Nadir pressure we do not use anymore. We use IRP. Nadir pressure was the lowest value in one location. IRP is an average of over 4 seconds, which need not be continuous. Now remember one thing, if somebody has a very low amplitude contraction, earlier we used to call low amplitude contraction when it was below 30 millimeter of mercury was the amplitude. But now we tell it when your DCI is very low, for example, less than 100 millimeter of mercury per centimeter per second. And remember one thing, what is a very strong contraction? Earlier in the Chicago classification, earlier version, we said anything above 5,000 millimeter of mercury per centimeter per second should be considered as abnormal. Now, this has been changed. Now we say more than 8,000. More than 8,000, more than 5,000 is abnormal, but you don't consider that as a gross disease. But if it is more than 8,000, then you say jackhammer esophagus, jackhammer esophagus. So this is what you do when you interpret manometry. Typically look at IRP first. When you look at IRP, if IRP is abnormal, then means look at the peristalsis. If IRP is abnormal, but the peristalsis is normal, that means this is EJG outflow obstruction. EJG outflow obstruction. Earlier we used to call that as hypertensive LES, maybe early stage of echinacea also. But if IRP is abnormal, more than 15 millimeter of mercury, look at the body motility. If body motility shows pan-esophageal pressurization is in more than 20% of the swallows, that means 10 swallow more than 2, then this is type 2 echinacea. If it is a segment is showing pan-esophageal pressurization in more than 2 contractions, this is type 3 echinacea. On the other hand, if there is hardly any peristalsis, hardly any amplitude, then this is type 1 echinacea. Okay, there are several other variations which I'll not go to detail. Maybe you can take in the question and answer session. Like I told you, jackhammer esophagus, which is more than 8,000 millimeter of mercury per centimeters per second. I told you peristaltic break, like long transition zone, more than 2 centimeters and so on. These are some of the examples. Here, this is a normal manometry. This one shows that there is a hiatus hernia. Can you see there is a high pressure zone above, high pressure zone below? There is a high pressure zone above, there is a high pressure zone below, and there is in between a low pressure zone. This is hiatus hernia. And there are studies to show, that manometry is superior to endoscopy in diagnosis of hiatus hernia. You can see here the same patient has hiatus hernia. In addition, there is a long peristaltic break. So therefore, this patient is like the earlier patient that I presented, is likely to have severe GR. Rather, this one is more classic, like our patient that I presented. Hardly any activity in the body. There is a very low LES pressure. Some EUS activity can be seen. This one I'm trying to show a patient where you can see there is a simultaneous contraction. There is another contraction which looks like peristaltic. This may be diffuse esophageal spasm. So when all contractions are simultaneous, it is achalasia. When 20% or more contractions are peristaltic, but the others are simultaneous, this is diffuse esophageal spasm or distal esophageal spasm. This is type 2 achalasia, okay? And this one again type 2 achalasia. Remember one thing, when somebody has hugely dilated esophagus, you may get intrathoracic pressure is also high, because esophagus contributes to intrathoracic pressure. So therefore, between the contraction, if you look at, you find the intrathoracic pressure is rather high, not typically blue like as you are seeing in every patient, but it looks like yellow. This means this is a high intrathoracic pressure, possibly because dilated esophagus filled with fluid and food. Now this one is interesting. This one obviously is a very high amplitude contraction. If these are simultaneous, you will say it is panesophageal pressurization. But if these are not simultaneous, you will say this is jackhammer esophagus, particularly if it is repeated. But this is not for what I'm showing this contraction. What I'm showing here is, look at this alias. Each time the contraction is happening, alias is getting lifted up. So therefore, if you try to measure the relaxation here, it will look like alias is beautifully relaxed. This is called pseudo relaxation. This lifting up of the esophageal alias is happening because of the longitudinal muscle. Like in a patient in whom circular muscle is hyperactive, longitudinal muscle will also be hyperactive. Now this longitudinal muscle is lifting up the alias. So therefore, if you do not know, you will put your cursor over here, and then you may see that the alias is relaxing, and you can make an error, say this is not achalasia. And I have such patient coming from big centers, I will not name obviously, where they wanted me to see the dressing for a second look, and I saw this was reported as not achalasia because the alias is relaxing. But the placement of the sort of measurement area was wrong. Now, clinical utility of assessing alias pressure and emptying after manometry. See, sorry, Dr. Saraswat is sitting here, don't mind. When we treat hepatology patient, we split hairs, which is good, which led to good outcome of those patients. When we treat luminal patient, we lump them too much. We say you can do the way you like. That creates disservice to them. So suppose if you have done dilatation in a patient, what happens is, if somebody was suffering so long, you gave little bit relief, he becomes euphoric and you over-report symptomatic relief. You have to show objectively that you have done a good job. And this is a study to show that, where they treated achalasia patient, subsequently they did a time barium esophagogram to see whether they have done a good job or not. Those patients in whom time barium esophagogram showed that they did a good job and the symptoms was relieved were called concordant group. Those patients in whom time barium esophagogram showed that you did not do a good job, but symptoms was relieved, they were called discordant patient. Look at the recurrence, somewhere around 10% versus 77%. Can you imagine? And this is over 7 years follow-up, yes. Now, but this recurrence separation started in 1 year. Look at this, or even less than 1 year. So the separation started very early. So therefore, recurrence will be more if you did not do a good job. We wanted to compare, if I'm a manometry guy and I don't have a facility, let us say of time barium esophagogram, let us say my radiologist is not cooperating, can I tell the same by manometry? And I found that yes, time barium esophagogram does as good job as manometry. Sorry, this is written under review. This is published long ago. Sorry for the mistake. So therefore, this is my end slide. So I tell you, all these interpretation technique, truly speaking, if you want to learn, we have to have a workshop of 6 hours, 8 hours, or 10 hours. This cannot be taught in half an hour. But I gave you some concept. It is like, it is a curtain raiser. And I told you that if you want to learn more, go to these two books. Very comprehensive, not because I have been involved with it. I think the right one is the best book in the manometry which has come till date in the world. Thank you so much.
Thank you very much, Uday. I think, yes, I can see you clapping, Shobna, but unfortunately, we do not have a system for applause and the speaker the realizing how his audience is appreciating his presentation. As usual, a masterly presentation. Uday is a master of his subject and he's also very clear and lucid in his explanations. And Uday, I'm happy to say that almost 100 questions have poured in during the time you were speaking to us. So I'll start with a few of them, and then I think Govind and Shobna can step in with a few more. One of the things that seems to be bothering at least four people from different places is, what do you do? What do you do when you have in a dilated esophagus? This is Abhinav from Delhi, Vishal from Ahmedabad, Sudhir again from Delhi, Sanjeev Kar from Cuttack. Sigmoid esophagus, tight LES, the catheter will not cross. How will you get across to do a manometry? What is your practice?
I tell you that if you are using a solid, it's water perfusion system. When you are using a water perfusion system, you tie a thread in the tip of the catheter and then take that using an endoscope. But when you report, you must report that the catheter was passed using an endoscope because your LES pressure is going to be fallaciously low. Second is, if you are many a time, what we have done is water perfusion is not working. We took the patient to solid state system. And in solid state, it worked because the solid state catheter is more rigid.
Yes.
That is the second way. Third way is that ask the patient to sit. If you have a habit of doing lying down manometry, just ask the patient to sit. And while the patient is sitting, you give water to him so that he keeps on drinking a little bit, not too much, so that when he is swallowing, simultaneously you push a little bit, push a little bit, push a little bit. But I tell you, after all this, in 2 or 3%, you may fail. All your attempt may fail. Then what we do is that we do a body manometry and we write LES could not be crossed.
Right. Thank you. Dr. Rangarajan from Bangalore and Dr. Ankit Patel, they want to know something about characterizing a hiatus hernia on HRM. Particularly, how do you identify the pressure inversion or the respiratory inversion point? And what exactly is the utility of HRM in a hiatus hernia patient?
I tell you, they have classified this hiatus hernia into type 1, type 2, type 3, type all those. I don't think there is any clinical utility in my opinion. I'll tell you why. Like you say, type 1 echalalia, type 2 echalalia, type 3 echalalia. You know the outcome is different. So there is a clinical value. Similarly, you know, when you get something like in also fecal evacuation disorder, people have said, Satish Rao has said type 1, type 2, type 3. There is no value. You know why? Because you have not shown any clinical utility. Still, when you have asked, I will answer. Typically, what you look at is there a separation at all? So if there is a separation, there may not be any separation. That means separation between what? Diaphragmatic pinch cock and the smooth muscle areas. Is there a separation? No separation. Okay, very good. It is the most healthy LES one can talk about. The second is there a separation? If there is it less than 2 centimeter or more than 2 centimeter? If it is less than 2 centimeter, till people will say, oh, it looks like little unhealthy LES, but not too bad, not too bad. Now then, if this is more than 2 centimeter, you look at the respiratory inversion point. I'll give you what is the concept of respiratory inversion point. Let us say if I have a manometry catheter and the ports are in the stomach and the fellow take inspiration, what will happen to the pressure? The pressure will go up because intragastric pressure rises on inspiration. Why does it rise on inspiration? This is because that the your diaphragm is coming down. So therefore, intra-abdominal pressure is rising. So intragastric pressure will rise. Now, suppose if I'm pulling that catheter up and it has come to LES, what will happen in inspiration LES pressure? It will rise. Why will it rise? Why should LES pressure rise when I take inspiration? This rises because the moment intragastric pressure rose, there will be an attempt for reflux. And nature has made a mechanism that reflux should not happen. So therefore, ileus pressure will rise. So stomach pressure will rise on inspiration. The ileus pressure will rise on inspiration. But the moment your port has reached the thorax, during inspiration, the intrathoracic pressure will fall. So that is inversion. So that is the inversion point where reverse has happened. And look at whether the inversion point is below or above, that becomes type 3A and B. But I tell you, this doesn't have till date any clinical utility. But I know most of the automated software will want you to tell what type of ATS are you seeing.
Right. Okay. That was quite a detailed explanation. I'll just have one or two quick questions and I'll ask the others to take over. Regarding achalazias type 1, 2, and 3, a question from Dr. Sagar and also Samir Patel. Sagar is from Delhi, Samir Patel is from Chennai. Is this a progression? As you said, type 3 is the earlier stage, type 2 is later, and type 1 is the most burnt out advanced stage. So in every patient, do you expect a continuum and a progression from type 3 to type 1? Or are they separate diseases? And similarly, I think Samir's question is that if type 3 is earlier, why does it not respond well to pneumatic dilatation?
Yeah, very good question. You see, what happens is, I'll tell you why achalasia occurs. Esophageal muscle typically is syncytium. So what is syncytium? Syncytium means all the muscle fiber is interconnected with gap junction. So that means the moment one esophageal muscle is depolarized, whole of the esophagus has to get depolarized. Whole of the esophagus. So that means the normal behavior of the esophagus is simultaneous contraction. It is like normal behavior of people is to go out and do loitering outside. But because of the lockdown enforcement of law, we can't go out. So then what is enforcing the law here? It is nitric oxide. So what nature has done is that normally cholinergic system causes contraction and that is responsible for simultaneous contraction. But nature has given a nitrinergic system, and the nitrinergic system is higher in quantity in the lower esophagus. Therefore, you have a simultaneous contraction. When there is a degeneration of the nitrinergic system, what happens is you get achalasia. First is type 3 because there is a segmental loss of the nitrinergic system. Then you get type 2 because it is a more diffuse loss of nitrinergic system. So the gradient between the upper and lower esophagus is lost. Now, what do you get later? You get Wallerian degeneration of the cholinergic system. Because you know, in neurology, any nerve goes off in the periphery, there is a backward Wallerian degeneration. That's why people have shown a Lewy body which occurs in Parkinsonism in brainstem of achalasia patient. Now, what happens is now cholinergic system goes off and therefore it becomes type 1. Now, when people classified, maybe because of the commonness of type 1 and type 2, they classified rather than looking at the pathophysiology, and later they realized the pathophysiology. If you want me to tell, does it evolve like this? Yes. There are case reports, there are small series in which people have shown even distal esophageal spasm and diffuse esophageal spasm first, then type 1, type 2 achalasia, and so on. Even there are case report of hypertensive ileus going to type 1, type 2, and type 3, and so on. Obviously, type 3 first, then type 2, and then type 1. Now, whether it happens in all patients, we don't know. We don't know because all this literature comes as case report and small case series. Whether it happens in everybody is not possible because you can't study natural history of a disease for the fun of studying and reporting results.
Why doesn't type 3 respond well to pneumatic dilatation? Could you take that?
Yeah, that's right. That is a difficult question, but I tell you, what are you doing in pneumatic dilation? If you look at, like I remember one patient I saw, this was a patient of achalasia. He had a very long non-relaxing jaw. Now, what are you doing in pneumatic dilation? You are using a 5 centimeter or 6 centimeter balloon and only dilating one part, but your long jaw is around 8 centimeter. Therefore, it is not responding. If we had a balloon to do a very long length dilatation, maybe it will work. That's why people have shown that if you inject Botox over a long length, it works. Poem long length, it works. Heller's myotomy long length works. Because it is a long length disease, that's why it is not working.
I think Govind, you could take over if there's anything. Muted.
Govind, you are muted.
You are muted.
Dr. Bhatia?
Okay,
Yes.
so I have, out of all the 100 cases, I've taken up 3 or 4 that are relevant.
Uday,
120 now.
Uday, only short answers because time is limited.
Yes.
Only short answers, yes.
Okay, so there are 1 or 2 very important questions that have been asked. One is, what is the position of the patient? Is it standard, or do you, or can you change the position, and will the values change?
People have shown that different position changes the values, and therefore you use a standard position for yourself. You are supposed to do validation of the normal value for your lab, or otherwise you follow the position what others have done. Like I know Srinivas has done normal value study published in neurogastroenterology motility.
Yes.
So use the same position.
Okay, and what about a patient who has a first few swallows showing type 1 achalasia, and then the rest of the swallows are showing pressurization? Would you classify it as type 1 or type 2? This is a difficult problem.
I will see ultimately that Chicago is quite silent about it.
Yes.
But I think pathophysiologically, you see, as you put more volume of into the esophagus, the contraction is going to increase. So if you want to know the natural situation of the patient, use the earlier values, not the later values. In the later values, you have stretched the muscle and you are getting a bigger contraction.
Correct. Now, the other important thing, and this is very important, not only for manometry, but for many other automated systems. Let's say the system provides you with a diagnosis at the end of the analysis. How reliable is this diagnosis, or should you be physically analyzing each swallow as you go along?
You see, do not rely on automated analysis. I showed you one example glaring.
Yes,
Obviously,
correct.
some people, what they do is that they don't look at the signal very well, clicks on automatic analysis, and whatever they get, then there is no need for doctor. Typically, each swallow you see visually, if there is a discordancy again, think, and you can't just go by automatic. I say, I don't like automatic.
Correct. I agree. And I think it's also important to go by the clinical picture of the patient and not just go only by the manometry. Last question, I think that's relevant for all of us, not only for manometry. What is the scenario for manometry in the COVID era?
Should you be doing manometry in the COVID era?
Yes.
Very good. I tell you, we have made a guideline. The guideline is going to GART. This is Asian Neurogastroenterology Motility Association. I don't know whether it will accept it, but it will. It is going. No, manometry is a high-risk procedure. Esophageal manometry is a very high-risk procedure. It is too much aerosol generating. Between esophageal manometry and the anorectal manometry has been rated as marginally safer. But let me tell you, 50% of COVID patients excrete the virus in the feces. Yes. So I'll say none of it does.
Correct.
True. Uday, it's a wonderful, wonderful talk. And let me ask you one other question, which is very interesting, that how do you treat ineffective esophageal peristalsis?
You see, you asked a good question, I tell you. Many of these patients have associated dysphagia and reflux. So I'll give a PPI, I'll give a prokinetic, and I use pyridostigmine a lot. When I get a patient like this, I use pyridostigmine. Now, prucalopride actually works or increases the activity of pyridostigmine, prucalopride. So in the prokinetic, I like prucalopride there. I use pyridostigmine, and even we have shown that on pyridostigmine, not only symptom improves, even the motility pattern improves. So we are planning to do a randomized control trial on this. But there is data. I know 7 studies are there, not in relation to esophagus, whole gut. There are 7 studies, and we have just communicated our data of 60 patients, wherein 7 we use pyridostigmine, and it worked.
And even Sagar from Nagpur says that his question was, can you use pyridostigmine?
Pyridostigmine for the island, yes.
In fact, you say that we can use it. Right. And what could be the dose and how long do you use?
See, typically, I am not a neurologist, so I am very cautious. I typically will start maybe in a low dose, 30 milligram BD, and gradually increase.
And how long do you use? How long will you use? That is very important.
Problem, if somebody has a defect from the beginning, he has a defect. Now, therefore, you have to use as long as they need.
Okay, there are many more questions. I don't think we'll be able to take many more questions in interest of time. So Dr. Ghoshal will send all these questions to you for your attention. And if you read these questions and if you can answer some of these questions, we'll be very thankful to you. And then these answers can be sent to every person who's participated today and for their knowledge base. So thank you, Dr. Uday, for a wonderful masterly talk. And as Dr. also said, that we applaud your efforts, your expertise in this area. We, all of us know that you are the star in this field in our country. And we all look forward to your presentations. Everybody enjoy your presentation whenever you speak. So thank you again for kindly consenting to this webinar.
Thank you, Suri.
Thank you, Dr. Bhatia, again,
Thank you.
as graceful as always, and
Thank you.
bringing value to this these webinars. And Dr. Saraswat, thank you so very much for again supporting every time. So with this we end, but before we end, we will have a next webinar on this Sunday, that is May of 3rd, when we have a very important topic that is how do you diagnose and treat hepatitis B virus in 2020. And for that we have a speaker, none other than Dr. Shiv Kumar Sareen, and I think he's a world leader in this field, and it will be this will be our advantage that we listen to him on this Sunday, 12 to 1 on May 3rd.
Okay, thank you all. It's been a very, very, I think, educative experience for not just the rest of you in the audience, but for some of us on the panel also. Uday's talk has been an experience. 130 questions coming your way, Uday. Some very thoughtful questions. See, you took so much time answering each of the questions live, so you'll probably have to write a paragraph for many of these questions. But I think given your deep insights, your interlocutors will value your responses. So we look forward to having them completed, sent off, and then eventually finding a place on the ISG website. Thank you all. And I think
also we'd like to thank our technical team, and they have done a wonderful job in relaying all these webinars almost nicely. I won't say flawlessly, but we always try to improve the quality every time. And we had some difficulty in our rehearsal time or trial time, but again, we could relate to this webinar probably nicely. So thank you, everyone. Again, thank you, Sun Pharma, for supporting this activity. Thank you, everyone, and bye-bye.